Good morning, everyone, ladies and gentlemen, and welcome to our session here this morning, the heartbeat of health innovation, how networks and collective action can help us cope with crisis and lead the way to a more resilient future. My name is Jan-Philipp Beck. I'm the CEO of EIT Health. We are co-organizing this session this morning. I'm joined by a wonderful lineup of speakers here today. They will all be introduced throughout this session. You see them here on the slide. I'm very much looking forward to a great discussion, and of course also invite all of you from the audience to join in as we progress. Now, allow me to say a few words about ERT Health and about the objectives of the session before we then dive right into our program today. So ERT Health is an innovation community supported by the European Union, supports innovators and entrepreneurs that address unmet needs in health. For the experts amongst you, we are part of Pillar 3 of the European Union's Horizon program, so as such a vital part of the future innovation area. We have a community that connects around 150 leading organizations, all exceptional, I would say, in the worlds of business, education, research, but of course also health and health service delivery. So we put a collaborative approach in place. We empower a network of innovators to really overcome barriers and challenges to really take action and put innovative products and new services into the hands that really need them most. And we try to bridge the gap between needs and demands, linking small players, large players across the entire ecosystem. So our goals are to strengthen healthcare systems in Europe, to promote, of course, better health of patients and citizens, and to contribute to sustainable health economy in Europe. And they are all shared, these goals, by the partners that we are working with. We work in our partnership to develop and accelerate the launch of new cutting-edge products and services that can also improve, of course, the care of patients and citizens. We support new and promising health companies in Europe, allowing them to thrive and to grow. And we also work in the field of education and training within healthcare ecosystems to close the skills gaps in health and support future-proofing our healthcare systems. Now, what we want to do today in this session is to reflect on the trends that are driving healthcare transformation and innovation, and also explore, of course, from the perspectives of innovators, policymakers, patients, healthcare professionals, and providers, how whole of society may contribute to a more resilient future. And we believe that the role of innovation in the transformation of healthcare systems is key. It's also a core theme under our 2021 think tank work. We are currently also developing a report focused on the role of innovation in supporting resilient and sustainable healthcare systems. And as such, also smart and sustainable financing is a core theme that we will be examining in this work. Now, first, I would like to invite Hans Martens to join me on our virtual stage. Hans, I think, is well known to most of you. He's the chair of the Coalition for Health Ethics and Society at the European Policy Center. And he's also a member of the ERT Health High Value Care Forum, which is an advisory board that supports us at ERT Health. So Hans, welcome to the session. And I think we will kick off the session with a brief conversation before we then move forward with the panel. Welcome, Hans.
Thank you very much indeed. And it's a pleasure to be here today and also be part of this whole essential discussion that we have today, which is also linked very much to what I advise on in the EIT High Value Group, because this is really about creating value for patients, for the health systems, but also for our societies where the money is a bit tight these days. So thanks a lot for that introduction. And I look forward to the discussion because we're going to have some examples today. We're also going to have an excellent panel discussion at the end of or the last hour or so of our discussion here. So I look very much forward to that. So back to you, Jan-Philipp.
Yeah, thank you very much, Hans. And I think we're gonna kick off a little bit in dialogue here, and I believe you have a few questions for me, I suppose, before we then dive into the examples. Is that right?
Yes, indeed, I do. And I think the first one is very much linked to what I just mentioned. The fact that I think even before COVID, we had health systems that were under pressure in Europe. I think the demographics plays a role. I feel myself responsible being part of the big generation after the Second World War. But you know, with the comorbidities and the pressure, financial pressure on the health systems, I think everybody has been talking about health system transformation. We want to get more out of it and so on and so forth. But my question to you, because of what you do, is primarily, if we want to ease that pressure, how does innovation in health ensure that we get more for our money, or maybe at least can increase the output, if you like, of the health systems? Because the thing is that everybody talks about transformation, everybody wants innovation and so on and so forth, but can it actually help? And the second question linked to that is, how do we actually measure what the value is that we get out of health? Do you have any ideas about that?
Yeah, thank you very much, Hans. It's a bit the billion or trillion euro question. So I think the importance of sort of smart investment, of course, is not new, and given continued sort of budget constraints, we ought to focus on that. These constraints have only been, I think, become more evident through the pandemic, and are even more urgent to be addressed. And I think essentially, which is, it's not a new concept, of course, but I think it's even more vital than ever before, is that we need to shift away from a maybe cost-based or pay-per-service approach, and focus on delivering on outcomes that really matter to patients. And for this, of course, also patient citizen engagement is key, to also involve them in the definition of those. And that might require maybe additional investment, but ultimately it might lead to better spending, and also hopefully help us to contain costs, and I think also limit waste, for example, on spend on unnecessary treatment. So I think we ought to focus on health and well-being, and we need to structure and restructure also the incentives in the system to pay for those outcomes. And I think that innovation at various levels can play a role. Now, of course, there is a lot of, and a big job also for policymakers to be done in that space. What we believe we can contribute from EIT Health is that we are essentially a diverse community that is focused on delivering projects that can create great examples, right, from which we can derive learnings that may also help inform the policymaking process. So, and that, I think, requires that we will put also projects forward that accelerate and utilize new innovations, but also couple that with the implementation of new business models, and ultimately also lead to maybe different contracts that can be implemented, new relationships between payers and providers. So this is what we are working on. Of course, also never forgetting the important dimension of education and training at various levels, because we also need to bring about, I think, a shift in mindset, a shift in culture as to how we look at the system and its performance.
But I think we'll come back to the question about how we make that more inclusive in our societies. But I think one of the points you're mentioning was try maybe not to look at spending just as cost, but also as an investment. And I mean, try to see what the value is. And you mentioned what matters to patient, but this is also, I think, to a very high degree, what matters for our societies. So the question is, can we change policymakers' thinking in this direction, to think about, let's say, spending on innovation as an investment that will have to bring some value back at a later stage? Do you think that's a tough process, to be honest?
I think it's a tough process, but I think it's necessary, and I believe that if we focus on outcome that matter to patients, I think we also have a chance to drive up efficiency if the focus is really put on that element. And I think also what will be extremely important is to create proper transparency in the system. So I think we need a common and good understanding of outcomes and value, and also understand where we see sometimes in the system the great variation of those outcomes, and tackle those and see how we can improve in those areas.
Jan Philip, the EIT means the European Institute of Technology and Innovation, by the way. But technology is the focus here. So when we talk about innovation, do we only talk about technological innovation, or what about innovation in processes? I mean, that's, for example, the whole health system, where we have been very much focused on hospitals and equipment and so on. And I mentioned the demographic threats, the increase of chronic diseases before. What about if we wanted to change the direction here? What if we wanted to focus on, let's say, diagnostic equipment and extract more value of that, move to prevention and so on to meet some of the challenges? Is that something that EIT also works on, or are you focused only on the technology side?
No, I think from the very beginning, when we started our work around 5 to 6 years ago, it was very clear that let's say a technology push approach alone is not sufficient. Frankly speaking, though there are great advances, of course, in technology that we also support, it's only part of the equation, and there is also a great availability of technologies that needs to be implemented. So I think we need a holistic view. And we need to look at different dimensions of innovations, and that includes, of course, a view of improving entire pathways. Also, of course, we need to look at processes, at potentially new business models. I think that doesn't make it simpler; it makes it more complex. But I believe we need such a holistic approach, and that's in EIT Health at least. When we are talking innovation, it encompasses all of those areas.
There are many different groups involved in this, and each have their their domain, their silos and stuff like that. What you are talking about when you talk about transformation is new ways of doing things. Do we need to, not only educate the population, but also maybe the health professionals in this respect?
Totally, and this is also, I think, where our greatest focus is put, because with the partnership that we have, I think we have a great possibility to reach to the professionals that are working in the system and shaping it. And I think, first of all, to create a platform where trustful collaboration can happen, where you can have an open exchange for ideas, but where you can indeed also discuss new models and trends, and of course put tangible also, for example, programs in the domain of education forward. I think that is very, very important, and I don't think it exists anywhere else, also with the European and an international dimension.
I know what I'm going to ask you now is not really your responsibility, but you know that money matters in some respects. And if we want to drive this development there, you also need in some way to think about how do we reward transformation, how do we reward new ways of creating value for patients and for society as well. It's something we'll come back to in the panel discussion, I'm sure, because we have a payer representative there. But do you think that we need a reform as well, and innovation in our reimbursement systems to drive this development?
I absolutely think so. I'm also curious to hear the views that will be brought forward with the panel. I think this is also, of course, a discussion that is very much ongoing, and we also see a lot of movement already. But I think it's critical that we rethink reimbursement systems and reward. I think aligning stakeholder interest in this is extremely complex. And I believe what ERT Health can sort of offer is that maybe in a way of by example, by flagship projects, maybe show in concrete areas, tackling concrete pathways, how this can be done. I believe is something that has to be moved forward. Actually, I think to a large extent the theory is really there. What's lacking is alignment to embark on impactful implementation.
Yeah, it's something we actually work on in this advisory group that you talked about. But the thing behind my question is the fear that we focus too much on the technology and the beauty of the technology in itself, and maybe don't think that the decisions about health system transformation is taken elsewhere. You know, it's at the political level, where, in my opinion, there's been very, very strong cost focus, which leads to some short-term solutions and so on. But I think you basically agree a bit in that, right?
Well, I think understandably so, of course, but I believe it's also then partially also responsibility maybe of innovators to better engage also and maybe payers early on in the innovation process to demonstrate clearly the potential, the value that can be delivered, and also to understand the pressures in the system really well, and not start with that engagement once you are basically done and a new solution has been developed, but do have a collaborative process from early on. I think that's something that is that's key, and that try also to implement in EIT Health.
Yeah, because I'm also thinking out here how you reward the innovations, because if you want to give the incentive for continued innovation, you need in some way or another to recognize the value, if it's there, on the innovations and reward that, rather than maybe just focus on traditional ways and so on. I have met examples where you continue with traditional ways because it pays better under procurement systems, although it's not good for the patient, it's not good for society, and only maybe just for making money for the health system. So what I'm thinking about is also, it's just about not paying solely for the innovation, but also for the value it creates. And if I may, on the question of prevention, for example, one thing is a diagnostic test, you know, what do you get paid for that? But the other thing is, because you were talking about pathways, what does that help by generating more data, more knowledge to prescribe more efficient pathways, which also leads to less waste probably in the society. I still have this shocking figure from the OECD that about 20% of all costs in the health system are waste. I mean, that can be discussed, of course, but that's what they basically have found out. And I mean, one of it is maybe not using the right pathways. So this is one way of innovation and transform the health systems.
Yeah, I think I would fully agree with you. I think finding indeed, for example, tangible, let me say business models also for prevention could be extremely important. I mean, to give you one example for I think a really successful project that we ran for a number of years in Northern Europe, in Sweden, which is called the Health Integrator, focused on actually identifying a population that was at risk of type 2 diabetes, and then targeting those individuals also with basically a suite of quite personalized support with preventative interventions, and then to finance that even without wanting to go into too much detail, with the engagement of payers in the region, with the sort of societal impact bond, which has also actually been awarded as a quite innovative, let's say, investment mechanism. And that also involved, for example, employers and so on. And I think those can be, so here we combined a new health service delivery approach, also to some extent new technology to support the early identification of population and people at risk, together with a quite innovative financing mechanism. And of course, that is just a that is just one project that now will need to demonstrate its scalability, but it actually also sees now also private investment around the company that is deploying those services. So I think there are ways, right, to go about, and I think innovators can certainly contribute potential solutions and show what may be possible to tackle these admittedly enormous challenges.
You said it's just one example, but it's a good example because it focuses on one of the, I can't call it pandemic, but one of the great challenges, of chronic diseases that spreads so much in the European population. So if you could do something to prevent or to delay the consequences, I think that's a very important step to take, and it is important that it's rewarded. But one more question before we go to the innovators. Will also this innovation force us to think a little bit more about, I mean, I'm talking about the situation we have with the comorbidities, the elderly generation, the spread of a lot of diseases that can be not so serious if they detected at an early stage and so on. But do you think some of it, do you think we need to think about treating some of it out of hospital, more and more at home? Are there innovations that points in that direction? We know that hospitals will get enough of clients, so we don't worry about them, but it's a costly place to be. It's a costly place to do the test and maybe some of the unnecessary things. Do you have examples of treatments that can be done outside of the hospital environment, at home and so on for us?
Yeah, well, I think that the future will be in those more integrated solutions that look at a pathway that spans several institutions or different layers of care in a very comprehensive manner. And of course, I think hospitals are not the place where you should remain for a too long time. I mean, we have now a first project coming forward to start next year in the area of stroke that looks in a very holistic manner at the pathway of taking care of stroke patients, and we will be looking also at putting new, let's say, value-based, outcome-based mechanisms in place. And there is a very holistic view on it that we definitely will try to see how also discharge, for example, from the hospital can be accelerated and so on. I think these are there are a lot of good approaches, and there's a lot of good thinking there out there, but we need to pursue this much more forcefully. And yes, I think it's integrated care will be the future. And I think, interestingly enough, now with the pandemic and the strong focus on advent of digital health, and with so many healthcare institutions being also limited in their capability to actually admit patients, maybe that has also given this move from hospital to home and other ways of delivering care. I think a push, and will hopefully also be a trend that we see accelerated in the future.
I'm sure that the pandemic has done some good as well. When we look back on some years' time, telemedicine is one. But I talked to a hospital director here near Brussels not so long ago, and he actually said the same as you were saying. The pandemic and the fear of bringing people into the hospitals and so on actually made put more pressure on home care, for example, as a part of this. So maybe in the long run, it will be better for society. At the precise moment, the hospital didn't make money out of it because the volume was not as high, and the expenses were not so high. But that's why I'm asking about the reimbursement systems, because they should probably reward those kind of inventions. But one last question here before we go on, and Philip, the thing about innovators, have they been sort of paralyzed of the pandemic, or have they used it as an opportunity to come up with new ideas?
Well, I think from what we have seen, all of us, I think the innovators' response to the pandemic has been amazing. I think we've witnessed a greater willingness also of researchers to pool resources. I think also in the area, for example, of overcoming resistance to sharing data, the engagement of citizens and patients of this. I think there have been real step changes. I think we've also seen, as I said before, already seen the uptake of digital solutions that has been going much faster, and that has of course also been due to innovators being quick at proposing and supporting such solutions. So I think overall, I mean, let alone the ability to so quickly adapt to a changed environment, enormous pressures also on those that were at the front lines of care. And I think overall the entire sector has been performing amazingly in over this time of the pandemic.
May also be now in the coming years that we can benefit from the developments of doing more at a European level, because we know that there will be more emphasis on health on the EU budget and in the EU as such. And it is not for EU to take over the health systems, but actually to use our resources better in exchange. And I think the health data space that will be coming would also help us in that direction there. But the question is, you're saying this helps, but do we have any examples of that?
Yes, and I mean, I think we have a few examples also that we can present in this session if we.
Oh, I didn't know that. I was just guessing, right?
Yeah. So look, I mean, what we have been doing as ERT Health, and of course, I mean, with our capabilities, our contribution, has been one amongst many different actors. But we had basically very quickly, when at the start of the pandemic, sort of 3 areas where we kind of took action. One was that also with the support of the Commission, we recruited very quickly within 3 weeks a portfolio of projects that really supported rapid response for implementation concretely with healthcare providers. We then also set up a kind of what we called a marketplace to actually just link people across the community, where some had resources, knowledge, whatever to offer that other may have needed. And we finally also at that point in time provided some very specific support to some startups that had important solutions to offer. And let's remember, at the very beginning also saw a devastating shortage also in investment readiness and financing. So this is something that we tackled with what we call the rescue instrument. And there are 2 examples, Hans, if I may, that we can look into. One actually from that kind of just matchmaking activity, which may be, one small seed in the contribution, but I think it evidences quite well how the community got together. And another one also from a startup that has been doing remarkable work. And so the first example, I would like Teresa Chavarria to join us. She is the Director General of Research, Teaching and Documentation of Salud Madrid. And Teresa, you're going to be presenting the ventilator project that moved forward also following a connection that we helped to facilitate. And maybe you can tell us a little bit about your experiences, your project and its impact over the next 5 minutes. That would be great. So Teresa, if you like.
Thank you very much, Jean-Philippe. Good morning to everyone. Yes, I'd like to present the main project that Madrid worked in during those first weeks of the pandemic. I think that if you could project the first slide. I think that first of all, it's important to frame the situation of our health system during those days. I think that the crisis generated by COVID-19 has had a big impact on most of the EU member states, countries, all at the social, economic, but also at the health level. In the case of Madrid, Madrid had to developed a new model of healthcare system by the development of flexible plans and reorganization of the primary care healthcare assistance. We had to collaborate with private healthcare system or models. We worked with one single intensive care unit. We had to purchase material, and also we have to develop new models, innovate on new models of healthcare assistance, such as Nightingale hospitals, medicalized hospitals, and the construction of a new hospital dedicated to the pandemic. Next slide. So during the first weeks of the first half of March, Madrid suffered a very, very rapid spread of the virus with an exponential growth of the infected population. You can see this better in the next slide, where you can see the high number of hospitals, of patients in hospitals during those first weeks. And due to this situation, next slide, please, Madrid had to respond through the healthcare and the social healthcare system. We had to increase the number of beds in hospitals. We have to double our intensive care units. We have to purchase more ventilators, and we had to develop new models for healthcare systems. And something that we are really proud of is that in those first weeks, back then in March, we were able to present more than 300 COVID-19 projects and clinical trials to public and private calls. Next slide. And one of these initiatives was, in fact, part of the EU's collective efforts to tackle the COVID-19. It was the EIT Crisis Response Initiative. The EIT Governing Board decided back then in 14th of May to mobilize over 60 million euros to fund new projects dedicated to the pandemic response. And on September, on 8th of September, I think it was, over 207 innovation projects and ventures from 32 countries were awarded with these funds. And in the case of Spain, through the EIT Health community, we were able to present different projects. And in the case of Madrid, we were part of an initiative that was integrated into the Making Connections initiative that was launched by the EIT Health community. In what we did was we developed an EIT Health COVID-19 task force that enabled us to start working on a project aimed at the sharing of ventilators among patients. This project, although it didn't see the light finally as the pandemic situation did not require it, made us possible to develop connections with other countries and other healthcare professionals in a project that was led by one of our head chiefs of the intensive care unit of one of our main hospitals in Madrid. And due to this effort of making connections from the EIT Health community, we were able to develop a network of professionals from different disciplines and different profiles that made it possible to work on future projects that were presented later on different initiatives in the framework of EIT Health. And next slide. So next slide, please. So I would say that if I could summarize our lessons learned from these past months and our future challenges, I would say that health research and innovation is a necessary and sufficient condition to face and overcome health emergency situations such as this pandemic. I think that during the pandemic, member states' innovation ecosystems met all the requirements to face the challenges of the pandemic. But I think that maybe we were not prepared in terms of strategy and planification. And even though a great effort of coordination and communication made it possible for the development of some relevant projects. And probably our main challenge now as a health innovation ecosystem is to develop more strategy and to plan our future participation in future emergency situations, And I think that what we have to do is to do this, healthcare providers have to be in great connection and communication with innovation providers, with innovation makers. We cannot advance in the healthcare system if we do not work hand in hand with innovators. And well, I hope that with this you have an idea of how we can work together and develop innovative projects. Some of them don't see the light, but nevertheless, these connections help us to build a better future in the innovation system. Thank you very much.
Thank you very much for sharing your experiences, but also conveying kind of your learnings from that time. Thank you so much. I also want to invite Carlos Mora. He's the CSO and co-founder at Hemotune, and Hemotune is one of the startups that we supported also early on in the pandemic. I think it's fair to say, Carlos, at that stage, probably your quite successful trajectory was a bit at risk, and it was important for us to make sure that we could support your successful pathway, and I believe that has been quite a sustainable decision. So, Carlos, why don't you tell us a bit about Hemotune, where you stand, and about your innovation and learnings?
For sure. Thanks a lot for the kind introduction, Jan-Philipp. It's absolutely true regarding the risk situation, and I'm coming to that in a minute. First, I want to shortly introduce what we are doing at Hemotune, and then afterwards talk about how also EIT Health helped us during the pandemic. Hemotune is a medtech company located in Zurich, Switzerland, and we were founded in 2017 as a startup, as a spin-off from ETH Zurich, the Swiss Federal Institute of Technology. And we are developing an innovative extracorporeal magnetic blood purification treatment based on a novel type of magnetic nanoadsorber material. And for our first indication, we have chosen one of the biggest healthcare problems nowadays, which is not COVID, but it's sepsis. Causing 11 million deaths per year, sepsis is one of the greatest medical challenges of our time, affecting both the developing world and the most advanced healthcare systems, such as ours in Europe. This life-threatening condition is caused by a misguided systemic immune response against an infection with bacteria, fungi, or viruses, including COVID-19. And with no effective treatments available today, sepsis ultimately leads to organ failure and death in up to 50% of all cases. Various compounds that are distributed in the bloodstream play a crucial role in the progression of sepsis, and the most direct way of cure would be the removal of these harmful compounds from the bloodstream. With our innovative approach for blood purification, we can simultaneously and precisely remove multiple of the sepsis-causing compounds from the bloodstream at a before unprecedented efficiency and selectivity. The goal of our therapy is to restore immune balance in septic shock patients. Thereby, we aim to shorten the length of stay of these patients in the intensive care unit and lower mortality. Currently, we are in the midst of preclinical trials and are planning for first-in-man clinical studies. So, to the next slide. Exactly. So, sepsis didn't go away during the COVID pandemic. Even many COVID patients in the ICU in intensive care units eventually suffered and died because of sepsis. However, as an innovator, we faced a high degree of uncertainty at the time. First of all, as many others, we had to shut down our labs, at least for a few weeks. Then the situation was chaotic, and planning operational activities was very challenging. More severe even, fundraising was not so easy anymore. Investors were suddenly more reluctant in these uncertain times to invest money in a company such as us. Money was mostly invested or was flowing into direct COVID-19 treatments or vaccine development, but not necessarily in companies that develop solutions for, in our case, a related problem or other important healthcare problems. So we had to come up with a strategy to get access to additional funding and continue our operational work and development work. One opportunity for sure was to investigate also the possibility whether we can use our treatment for sepsis also for COVID-19 patients. Thanks to the substantial EIT Health funding we then received, we had the capability to move our innovation further. We got resources from EIT Health in the form of around 500,000 euros. With these funds, we were able to successfully explore the possibility of using our technology for the treatment of COVID-19. And we were also able to speed up our product development, which helped us a lot. In the meantime, we could also secure then additional funds from private investors, which helped us to grow even further. Now to our learnings. Our learnings from this crisis were that we really saw how important it is that there are not only private institutions or private investors, there are also reliable institutional funding partners such as EIT Health that allow for fast and non-bureaucratic funding in uncertain and chaotic times. One of our recommendations is this also that governmental authorities and agencies in general make more investments into pandemic preparation and prevention, and also reward more the related innovations that are more tackling also underlying healthcare problems such as sepsis. Additionally, we have experienced ourselves that the pandemic hampered our ability to raise money. So I think it is important that for the next pandemic or crisis, which hopefully does not occur soon, it has to be ensured that the rest of innovation pathways that are tackling other health conditions are not blocked or left behind, because this would have for sure a dramatic impact on patients and overall population health. With that, I would like to conclude. Thanks a lot to EIT Health and its team for their support, and also for the opportunity, of course, to present our story and learnings on this occasion.
Thank you very much, Carlos. Great. And yeah, thanks for sharing your experiences and also your the insights into those strategic challenges, the pivoting that you and your team have done. I think that has been really impressive. And also, again, thanks to Teresa for sharing your insights basically from a healthcare providers and institutions perspective on how you have been moving quickly to address those unexpected and unmet needs. Without further ado, I would like to conclude that part of our session, hand to Hans, who will be chairing the panel for the remainder of our session. So Hans, the word goes to you.
Thank you very much. Thank you very much. It was also great to hear that all that has happened during the pandemic, and thank you very much for these introductions. But now I'm honored now to get the chance to moderate the next session, because we have a great panel here. Let me quickly introduce them very briefly. The first I would mention is Christine Dehn, who is a patient representative. We shouldn't forget the patients, obviously. It's what it's all about. She is a member of, or works with the Deutsche Herz Stiftung, and she's also part of the European Heart Network. We have Gunhild Valdemar joining us from Copenhagen, from Rigshospitalet in Copenhagen. She's a professor of clinical neurology, so a health professional. She's also a member of the board of the Biomed Alliance in Europe. And finally, we have from the Netherlands, we have Jeroen van der Balk, who is working on procurement-related data at the, and I'm not sure I pronounced this right, but Silberen Kreuz Achmen in Deutsch, a Dutch payer organization, and he is also a colleague of mine in the high value group at the EIT. So we have the three dimensions in here. We have sort of the health professionals, we have the payers, and we have the patients represented today. And I think the focus will now be about what we already have touched upon today, the question of resilience. How do we actually now transform our health systems on the basis of what we needed before the pandemic, but also what we learned during the pandemic? What should change? How should it change? How do we create value? And not only for the patients, but also for the hospitals, also for the health professionals, and of course, for our societies where the money is coming from in the end. So we have about 45 minutes for this debate. So I'll ask the panelists to introduce themselves and the subject and their opinions, and then we open for a Q&A with the audience. And I think the way you communicate is via the chat function. So we'll try to gather the questions and try to put them together and have a meaningful discussion for the last half hour of this session, more or less. But let me turn directly to the panel. And Christine, I hope you, Gunhild, I think you are with us, and I see you are. You just need to unmute, and then I'd ask you to go first.
Thank you very much, Hans, for this kind of introduction. I'm here to represent the Biomedical Alliance in Europe, of which I'm the president-elect. The Alliance has about 35 member organizations, all pan-European medical research societies, and represents 400,000 clinical and basic scientists in the field of biomedicine. I think we have a very big obligation that now that innovation should respond not only to the COVID-19 pandemic, but also to other health threats. So, and innovation must be based on research, and health research must be based on the needs of patients and driven by the needs of patients and citizens of Europe, not to forget. In brief, I think we need 5 specific elements to be put in place. 1 is adequate support to bring ideas for research to the patients. 2 is better coordination of health research across Europe and across European member states. And 3, better cooperations. We need new mechanisms to link and facilitate cooperation. EIT Health is a very good example. We also have the European reference networks and other initiatives that I think we have to support even more. 4th, basic scientists and clinical scientists are the drivers of health research. I think we should acknowledge that, and they should be offered much better advice and guidance and education and training on research aspect and also regulatory matters. And the medical societies of Europe are key in this process, of course. 5th, I think we should ensure that the right policy mechanisms and regulatory aspects are in place, because that in many instances creates barriers towards developing new treatments and also preventions for the citizens of Europe. And to go perhaps a bit more into depth, I think that it is clear that from the COVID-19 pandemic that health issues do not stop at the borders and require a European approach. Now that applies for communicable diseases as well as for non-communicable diseases. And I also think that lessons emerge that is the global interdependence of health and health research, and the power we can create by better coordination across Europe. And we need much better a system in place for that. So therefore, it's great that the EC has presented its ambitious Health Union initiative, but now we must make an effort to actually realize this ambition. Because we cannot achieve unity and better healthcare for EU citizens and equality and access also without better coordination of health research funding and more funding for collaborative and impactful biomedical research. So this momentum really should be used to invest long-term in our health systems to face the current but also future health threats and to facilitate innovation. And as such, the Health Emergency Preparedness and Response Authority, the HERA, and also the EIT are very key and useful for that. So it's important such initiative get the sufficient support and also have long-term visions to address the present health issues. But all the time we should keep in mind that our health scientists, our health researchers, our clinicians, they are really the base of research and the innovations to create based on the research. So they need all the support they can get, and from better coordination, better advice, better education and training. I think that these were my.
I would like to thank you very much for the introductory remarks. I mean, you touched upon the patients, you touched upon the health professionals. Let's make certain they also get the support, but not also create barriers, but we'll come back to that. And for the society and the European society. And yes, I agree with you. We could learn a lot from each other in Europe. I'm always saying nobody has the best health system in Europe, but if we combine the best of them all and begin to interest ourselves a little bit what happens across the borders, maybe we could get there. I'm not so sure. I agree with you that we all looked European when the COVID came, because there were also some people who were basically looking inside. But let's discuss that and maybe hope that we had learned that the successes of the cooperation was very good. Now, the question about the money we already touched upon when I talked to Jan Philip, but I think we have the real expert here, Jerome. If you would like to tell us a little bit about what you do and how you see the need for transformation to create more resilient health systems. Over to you.
Thank you very much. Thank you very much. Yeah, as a payer, we are very much interested in creating the most value for as many patients as possible, our insured. And one of the things that we found already a few years before the pandemic is that our patients, they don't mind to go to the hospital, but they prefer to receive as much care at home. And so we, in the Netherlands, but we also saw this in other European countries, a movement of trying to keep the healthcare at home. And for this, we needed a few things. We needed technology. But we also needed a different care pathway, and to help stimulate that, we needed a different reimbursement. So we have started a number of projects where we said, okay, we want to look at the entire care pathway from the GP to the hospital to the rehabilitation across the total life cycle of care. And in the Dutch society, but also in many other, well, in all countries, reimbursement is done on procedural level and not on outcomes. So also piggybacking on the trend towards more outcomes, like with ICHOM, where there's many more outcomes being measured right now, we said we want to expand it into outcomes that matter to patients. We always have these clinical outcomes, but for instance, with a person with a stroke, what for him or her is most important is how soon is he or she able to be able to participate in normal life again and work and this sort of stuff. So together with the healthcare providers, we have developed more longitudinal approach to care pathways, focusing on the outcomes that matters to patient, and also change the reimbursement system. So we created some projects where we said we will not fund the procedures anymore or the time spent by the healthcare professional, but we are looking at the outcomes also over a longer period of time, because that's something, Hans, you also discussed with Jan Philip, is an investment into either technology or a different procedure that will not pay off within a year or within 2 years. But these are long-term processes that take a long time. So setting up projects that last for at least 3 years, where we accumulate all the cost and all the outcomes, and then look at the end what the investment has paid off. And then we will talk to these healthcare providers and say, okay, this investment has created so much value for our insured and for your patients, and we will share the results financially. So it's very complex, because we need to tackle a lot of components. We need better cooperation between healthcare providers. We need incentives financial incentives to help them cooperate, because sometimes we are now shifting money from one type of provider to another type of provider. In the long run, that's beneficial for the patient and for the society. But in the short run, this might hurt a provider. So we said, okay, let's take away all these barriers, which are omnipresent in every healthcare society between the different types of providers, and make sure that the money is well spent from a societal perspective and not necessarily from an individual provider. These were very hefty discussions because they were, of course, afraid that if they would deliver better healthcare, they would receive less money, which is a very strange thing, of course, in our systems. It's like taking your car to the garage and then the mechanic says, well, I'm not going to fix your car too good because then you won't come back. So that's something we had to address, and that takes time. And that's what I like about the discussions we are having within the high value care group, but also the project that EIT has now just rewarded that will start next year, that focus on the total cycle of care, from the beginning for the patient to the end, cooperating with the payer to develop these incentives to look at the total picture. And well, that's one of your hobby horses, of course, the investment versus cost approach. So there has to be a focus on the total cost of care and the total reward that matters to patients. And it might not even only be clinical, but more in the participation of the patient. For instance, if you give somebody a new knee or new hip, you can measure if it's put in right. But what matters is if this patient can walk again, and if he or she can go shopping again. So there is a continuous shifting in paradigm in thinking towards this new way of approaching. And also within Europe, all our healthcare systems are different in the details, but they all focus on paying for procedures. And everywhere there's a payer that has the ability to look at the total care pathway and develop new contracts. So we don't need to rearrange the entire system, healthcare system, reimbursement system, but you need to add another part to the system that focuses on the reimbursement. And their payers, be they regional, private, public, they can do a lot. Yeah.
Okay, thank you very much, Jerome. A lot of thought-provoking things, actually, that we sometimes pay for what we shouldn't be paying for in the long run. And I don't think that you're saying that we should turn procurement systems or rewarding systems into European scale, but you can probably learn from others what works best in the direction of creating the value. And often the value creating for patient and society is the same. I mean, if the patient can get out quicker and get back to work, that's good for society as well. We don't have to pay for care, but can actually have people back in productive life. So I think that's also a good thing that we can build on. But there's a lot of good practices around in Europe. But now it was all about the patients. So Christina, you are representing the patients here today. Are you only represented some of them, or the totality of the wide range of patients that we have in the European countries? Over to you.
Of course, I wish to represent all of them, but actually I'm a speaker or a representative of the CVD community, the patients. And Teresa and several, and you mentioned already the collaboration. And I think it's very important that the patient is included in these collaboration networks from the very start, because the patient knows what is of value for him or her, and as well as GPs or the specialists. For example, I can give you an example. We were always discussing clinical endpoints, for example. So for the researchers, a clinical endpoint is death or heart attack, or in CVD. So, and for the patient, it also can be improvement of life quality. So, and this is the patient who brings in this important point. And the patient know what is useful to him and what tools he can implement in his daily life and his daily routine. And but I would like also to address the benefit for the patient. So let me give you an example. if you have, for example, a tracker that or a reminding system that tells you when to take certain drugs, the patient, what he does is he implements this new facility, new device into his daily routine, and this improves his treatment adherence. So the EHN, for example, is a partner in a EU-wide project called Big Data at Heart. And in the last podcast, they mentioned, an expert mentioned that from her studies that she realized that 50% of the patients don't take their drugs as prescribed. Do you know what this means? This means if all these patients would take their drugs as prescribed, this would mean less hospitalization, less medical treatment. So here's the potential to save money. But it is also perfect for rural regions where the patient can't go to the specialist whenever needed. But so the specialist can check remotely the vitals. And but it also has to make sure that it's an add-on and not a substitute. Patients really appreciate the patient-doctor interaction. So what you can't take this off from them. You have to sell this as an add-on, as an additional benefit. And then the patient has to be assured that that his data is protected. It has to be very trustworthy because it's very, very sensitive data the patient is giving away. And so we have to make sure that this is respected. And there are also obstacles. For example, we have a high percentage of health illiteracy. What does it mean? It means that patients don't understand what they are supposed to do and that we can't reach them with our good advice. So we have to make sure that the devices or digital solutions are easy. This could be pictograms. This could be very easy lay language. Here again, patient representative can help to develop all these or to overcome these hurdles. The thresholds have to be very low. For example, if you have a very nice digital app, which only works on the latest iPhone or Samsung or whatever brand mobile phone, how can you make sure that people that don't have enough money or a lot of money or elderly people can use this app if it only works on the latest mobiles? So these are simple things that we always have to keep in mind. And we also have to make sure that we integrate these digital tools or approach already in medical training, because who should show the patient how to work with this digital device? It can't be the doctors who already don't have any time left for explaining technical issues to the patient. So it has to make sure that we create new professions or new ways how to train the patient. And what else did I want to say? And we maybe should start already in schools, taking prevention measures, and our society is adapting to this digital. We are all pushing towards digital. Everybody is using smartphones or a step tracker. So this becomes the new normal. And we have to make sure that we catch all the people to be on board and to benefit from this. And for example, what also is very important is that we really push the electronic health records, so that when we cross the border, we don't have to, in one country, the drug is named XYZ and the other one is ABC. So the patient gets completely confused. So if we have an automatic system that we can really use it trans-border, this would be great. So, and yeah, I think that's, and the latest example, heart failure patients, for example, we have seen perfect results for heart failure patients. The more you monitor the heart failure patients, the less they are hospitalized. And this is at the long term. When we invest now, we save a lot of money long term. So that's all I wanted to say.
Thank you very much, Christina. It's not all you want to say, because we will have questions for you as well. But thank you very much for reminding us on not only the patients, but patients are different. I mean, we need to be inclusive. We have solidaric health systems in Europe. Everybody's health is our all concern because we have to pay in the end. So of that simple reason, but also of humanitarian reasons, we need to include and not create with the innovations in the digital development, not create new barriers or new inequality in our societies. By the way, the thing about the comparable data, I've lived in several European countries, and I had exactly the problems you said, but also the other question that you don't measure the same way. We don't even have standards for how you measure blood sugar or whatever it might be. So let's at least get that done quickly. I mean, what does it wait for? Because it's not only for treatment, but also I think for analytical purposes that we can use data from other countries to extract the best pathways. But thank you very much, Christina. And I will try to not ask questions because I had a million for you, but we already have things from the audience. And the first one, and I must say that we're a little bit after time, so if you could be sharp and precise in your answers to the questions, that would be highly appreciated, to put it mildly. One question from the audience. I'm not sure I understand it quite 100%, but maybe some of you do. Are the entrepreneurial solutions, I think this is the innovation we talk about, the answer to local community health needs, and how can we support these solutions on a wider scale? You know, how can we broaden it out? Does that ring a bell with any of the panelists?
Yeah, I think I do. I think it sort of relates to what Christine was saying about simple digital solutions that can help monitor patients. And you said it shouldn't be in the latest digital solution, but it can be low tech. There is the Nightingale project from the UK that started 7 or 8 years ago, where patients provided data via WhatsApp, and they can not only help the doctor provide better care, but also the family of the patient, because you can have a much wider network of caregivers around the patient based on these data. So I think it can also help in local communities. Yeah, and it may be the data collection is within the hospital, but the actual care is provided by the home care provider.
So what can be developed and used in local communities can also be scaled up. Any of the two other panelists want to say anything about this? If not, I have another question, which is from Sarah Mondier from Novartis. And she sees a lot of reluctance among civil society groups to go towards a value-based system as opposed to the cost-plus models. They see it as a way to charge higher prices and not a better system for patient and society. How can we demonstrate, or even better, that value-based, outcome-based solutions are better for the patients and not just best for the industry? I've heard that discussion as well in Brussels a lot of times, and mostly from patient groups. Is this just another trick to get more money in the back? Do you share that, Christina?
I think it's important to integrate the patient representative from the very, very beginning. And
so you mean also in the definition of the outcomes?
Yes, absolutely. Because then, because a patient knows what is of relevance, because you can produce or innovate super hyper products nobody's going to use. And this is, I think, what we also suggest is to do a test run, like, for example, that you really test it with real patients and not with the patients that the companies identify. So it's a good opportunity to go to neutral organizations or to the regulators and ask if they have any patients they can address to. So I think this might be a good way to really ensure that the product serves the needs.
Gunhild, what does the Biotech Alliance say to this?
Well, I think we need much more research also. So actually,
research on outcomes.
Yes, on outcomes, on value outcomes, value-based outcomes, particularly in chronic disabling diseases, where it is much more difficult to define a positive outcome, and at least takes longer time also. And in some cases, you cannot ask the patients, you need to ask maybe some family members or caregivers. So this is much more complex. It's easier if it is a new hip or a new knee than if it is chronic disabling diseases. And the chronic disabling diseases, whether it be lung or heart or brain, are really the future drivers of health costs in Europe. So that is where we should also invest in research across Europe.
Yes, And COVID has put its finger on this as well, especially on the chronic diseases.
Yeah, there's another question for another day, because we've never tested so many people as we've done during COVID, but did we really extract the full value? Do we really understand what COVID is all about? Can I also just say to Gunhild, you know, I have a few experiences with diabetes too, which is clearly a chronic disease. And I actually had a very good doctor once who said, you know, the blood sugar was a bit high, and he drew a very quick conclusion for me. He said, so, do you want to change your lifestyle, or do you want me to begin to amputate your legs? So, I mean, you know, sometimes it's not so difficult. And why don't we do screenings, for example, for high blood sugar, you know, in wider groups and so on and so forth, because we don't necessarily need medicine to cure the things. A lot of things can be delayed by changing your lifestyle and so on and so forth.
You mentioned it already, actually, that we should invest much more in prevention.
Yeah.
But actually, the clues to how to prevent disorders also lies in the patients with the various disorders. That is, from them we get the ideas, the good inspiration to what needs to be better for them. But actually, those same ideas and innovations may be useful in the prevention of the same disorders as well.
Yeah. Jeroen, are you afraid of the same as the groups we talked about, that this is another way to make you pay more for the products?
Well, sometimes I am, of course,
yeah.
But in many cases I'm not. The example you were just giving, amputation is not only very bad for you as a person, but it's also very costly.
Yeah.
So if we can prevent a readmission or exacerbation in case of more chronic diseases, this will save the healthcare system money. So I always say that quality saves money instead of costs money. And of course, there is a huge debate on the oncology medication and how much value does it bring. But so if you look over a bit longer period of time, you can very well see which innovations save more money than others. But then we do need real world data, and then we do need, like Christina is saying, real life patients, and not only the medical testing of, for instance, drugs where they are selected by the companies. So it does, from both the provider and the payer, it is a risk, because you're looking at a longer period of time. We're not looking at one week for a procedure. We're looking at 3 years.
No, but that's the thing, for example, with the diabetes, you know, it develops slowly, so you will only see it over a period of time. But I think it will also help that we have historical data, but gather them, but also can compare with other countries, because we all say, yeah, but the health systems are different. Yeah, but maybe the explanation is in different health systems. So that could be one factor of knowing why is people living longer in Spain than in Denmark, for example. I mean, why is that? Is that only because the sun is shining? Is it the food? Is it the health system? I mean, why are we not more curious about this? And why are you not doing that?
Yeah, and well, that's the example of diabetes is excellent. I mean, the models that have shown that a good prevention lifestyle in year 1 saves money after 40 years. And for me as a payer, that's far too long, of course. But the models are so good that I am willing to develop a contract for 3 years based on those models.
Yeah.
So of course it's not easy. If it was easy, everybody would have done it already. And a diabetes patient is a diabetes patient, no matter what health system he or she is functioning in.
Yeah.
So from content wise, there is a lot of cooperation possible with all the different modifications you have to do on the healthcare side. But
Plus
even there we can learn.
Yeah, but you can look into different degrees of health literacy and social status and so on and so on. But I have a third question that links to this from the audience. Are there any examples, maybe written, I think somebody looking for sources, examples of countries or regions where this kind of paying for outcomes and not for procedures has been tested successfully? Maybe we should just stay with you, Jeroen. Do you know? Do you have that? Do you think you have such cases in the Netherlands?
Yeah, we do. We have a quite active community of providers and payers, especially providers that are looking for outcomes, and that's been amply documented. Santion is a very good example of 7 hospitals cooperating, sharing information and improving their procedures. But also from Switzerland, we have the very well documented example of the group of GPs that were given more money as an investment to keep people out of the hospital, because that's where the money save is, of course. And like I said before, it's detrimental for the revenues of the hospital, but so that can be fixed. And a lot of money was put into the GPs and that saved money in the end. Yeah. And there's many projects that are described. For instance, BCG, Boston Consulting Group, has written a number of examples on value-based healthcare payment systems. Yeah.
So maybe just Googling some examples on internet will bring up some ideas.
Absolutely.
But
Google,
I don't think
Google helps. Yeah.
You will not have a lot of cases from Germany, Christine. You're not so advanced in the value-based healthcare, are you, in the German system?
No, unfortunately not. But I wanted to stress that it's not only that you also have to push the patient's own responsibility by educating the patient. Because once the patient realizes what he can do because he's always interested in his own health, of course. Yeah. So if he knows exactly what the problems are, and we've seen that not so well in Germany, I have to admit, but we've seen that in the development of the last 20 years in anti-smoking policy, for example. Because smoking has become really unsexy. And what we see is that figures are dropping. And of course, this is avoiding long-term chronic diseases such as cancer or heart problems. And I think we have to really focus on a dual path, training the patient, but also pushing collaborations and your own projects like the GPCs just mentioned.
Yeah, I don't know, Gunhild, if you have any particular examples, but if you have, I'd like to hear. But I'd also like just to hear your opinion as a health professional. Yeah, but then maybe you can answer this question, which is from me, basically. Do you think that health professionals, and I'm thinking about doctors and nurses in particular, can become barriers to this transformation that we talk about? Are there areas that you want to defend? Are there traditional silos? Do you not want to have the education in the new technology and so on and so forth? Yeah. I know it's a leading question, but I think you have the opinion, you live in it, and please admit if there are any barriers, right?
Yeah, of course. I mean there may be barriers everywhere. But in general, clinicians across Europe are interested in giving best value for their patients, and they are in dialogue with their patients every day. And I think that is really what they want. And maybe it is difficult. So many of them are not involved directly in the organization of the paying system. So that is sort of a general thought. But having said that, of course, there are barriers, and I mentioned some of them before. Actually, people are speaking about value, but what is really value, and who knows what is best value? We as clinicians certainly are not the best to know what is best value, but we are very near the people when we meet. I think the patients know very well, but they also have a barrier in the sense that they may not know all the opportunities that are out there. They may not know how well they could have been. So I think we need to collaborate, and we need to invest in research across Europe and in coordinated research that can make us much wiser, because I think it's the right way to go.
I sometimes have the feeling that let's say doctors are better at sharing the newest, clinical procedures and so on, and adapt in the high class medical journals and so on and so forth, and that spreads very much quicker than system transformation. Am I right in that? I mean, you're easier to pick up the best practices of clinical experience rather than administrative organizational experience. No, not true.
I think it's very difficult to make general considerations about the psychology of clinicians across Europe and across medical specialties. But what I do know is that we all have a common interest in creating the best value for our patients, but also for that to be based on research. And the best research, yes, is published in the best journals. So we should take a big interest in that.
And we also agree that the best procedure seen from the doctors and the patient side could be different, as Jerome was mentioned before. So we always need the patients to come in here. And I see the patient in the middle of the screen right now. But just before we go to that, I have a fourth question from the audience, which I could have asked myself, and I think I have done, but let's try to summarize the question, the issue. Isn't preventative health innovation, and we're talking about innovation now, the key to a resilient and transformed health system? Do we need more focus on primary care-oriented innovations? I mean, I think maybe Jerome will explain a little bit the thing about value-based healthcare and sharing between the primary and the secondary and so on and so forth. But the question here is really about, should we intensify the innovations in primary care-oriented facilities, technicalities, and so on and so forth, and then, and I'm looking at you, Christine, in particular, are we doing this for all the patients, or are we losing some? So maybe I'll start with you. Can we all join this empowerment of patients?
Of course, we are leaving patients out because it's very hard to address patients that don't feel sick because they're not sick yet. So this is really difficult. So we are, as CVD organization, we have real problems addressing the young patient, not patients yet, the 30, 40-year-old, because they don't think that they're going to get a heart attack. What they sometimes are afraid of is cancer if it runs in the family, but not a heart attack. And they're not thinking about heart failure, which is really not unusual the older you get. So I think it has to be ensured that legislation provides us the environment that we can educate and raise our children in a society that tries to prevent them from getting sick, which means we have to ensure that they have enough physical activity, that they have healthy choices, which doesn't stop at family houses. So for example, if you can't afford an apple, for example, shouldn't be more expensive than a hamburger. And fortunately, in my country, it isn't the case, but I know a lot of other countries where exactly this is the problem. And we should make sure that people understand how important it is to live a healthy life, not only for themselves, but also for society. So, and then again, if you reach, where should you start? You have to start somewhere. And it's especially difficult for us to address migrants, for example, or people who don't speak the language. So we have to find a way how to make sure that we integrate these people and the concepts. There are a lot of beautiful little regional small projects, but we have to make sure that not everybody is doing his own very little project, but that we have a more general approach.
Yeah.
But this is something we can be discussed for 2 hours.
Forever, yeah, we can. But it's important to remember that we should not use this as create a new inequality in our society.
Yes.
But Gunhild, I have followed a discussion in a European country. It is not the one you come from, but another one where basically there was an agreement. Now we need to do more for prevention, but actually because of reluctance in the system, that actually meant that you build up additional cost in the health system because you didn't transfer, let's say, from the hospitals from the secondary to the first, but you basically let the hospitals be where they were with the same investment, same cost, and so on. But then added extra money for the preventative part. Are you willing, and from the position where you sit in the biggest hospital in Denmark, to go on the way of saying not only we should do more prevention, we also want to move some resources from the secondary to the primary healthcare, or am I wrong here?
Yeah, in a way you are a bit wrong, because I mean, I'm not talking about my own hospital only, but the investments in prevention are long-term. I can just take from my own area of interest, which is Alzheimer's disease and dementia. If you think you should do more in terms of prevention, that will only come into effect 20 years later, right? So you cannot take away funding from treating the severely ill patients and give that to prevention and right away. So you have to invest long-term in prevention, and it is on the long run, for the majority of diseases, at least the chronic disabling diseases, yet that you will gain some of the advantages of that, also in terms of cost. So I think it's a misperception that you can simply just transfer from one to the other. And also in terms of reaching out to all people, all the citizens of Europe, I think Christine mentioned some very good exceptions, but we could also think at people who are literate. We still have a certain percentage of people in Europe who are literate, not only digital illiterate and health illiterates, but also basic illiterates in terms of reading and writing. And of course, we do have also citizens and patients who are not aware that they have any condition, for instance, psychiatric patients, people with dementia. So we cannot base development on their values only. We need informants. Mm-hmm.
I'm just holding up here a beautiful publication called Health at a Glance in Europe. There will soon come country reports out. It's done by the European Observatory, the European Commission, and the OECD, and it actually shows that we spend around 3% in average in prevention in Europe, and the rest on curing people. So, Gunhild, there's a debate going on there, and it will go on for a while. Jerome, you're the one who pays. My question was, are we willing to do you get acceptance for the idea I launched?
Yes, and I partially agree with Gunhild that it's an investment that will take time to materialize. If you look at the real primary prevention, but there's also a lot we can do already in shifting healthcare from the hospital to the GP, for instance, with chronic diseases like lung problems, keeping the people out of the hospital. That won't happen if we allow the hospitals to decide. So there also is some pressure from outside pressure needed. And well, we are always the boogeyman as a payer, so we can take that extra job as well. In gradually shifting funds from the secondary care to the primary care. And in the Netherlands, we already see happening that some hospitals are anticipating not only that we are going to do this, but also they know that with all the new patients coming in the future, if we do what we did, we're going to get what we got, which means overworked doctors, overworked nurses, a total shortage of personnel. So even if we look at prevention from a medical side, yes, of course we should do this, but also from a employment. There's not going to be enough people in healthcare to provide the care that we are providing now on the way we are providing it. So we also
with that, Jerome, I need to stop you now because the time is running out, and I know we could go on forever. I do not need to conclude the discussions because I really think that you have made your points very clear, and I think there's also a clear trend in it. So thank you a million times to Christina, to Gunhild, and to Jerome for your participation here. Thank you very much for a good discussion. Thank you also for the audience for your good questions. And back to Jan Philip.
Well, thank you very much, Hans, and thanks to all of you who've been following discussion very closely. And I would like to, indeed, thank you all for these great contributions. Just a brief attempt to wrap up with just a small selection of takeaways. I think it was very good points made regarding the involvement of patients and also the possible resistance that may be there, or the skepticism when it comes to moving to a different system, more outcome-based payments. I think this is very important to tackle. I also think it was great that the opportunity was highlighted to learn across borders, because of course what we know about the diseases, about the risks and so on, but also about patients, maybe their behavior is something that we can exchange, and even if healthcare systems are different, there may be good things that we can learn. I also found it a good conclusion that systems, of course, need to continue embracing innovation, that much investment will be needed, that may only pay off, so to say, later. And overall, I think what I take away is that it will be so essential to figure out how that transition can work, because there doesn't seem to be so much fundamental disagreement, at least on this panel, I believe, on what the goal should be. But I think the question on how we actually get there and how we transition, I think, seems to be quite fundamental, because it's complex systems, they are large, and tremendous investment is of course needed, and also change. So I think this will be important, the dialogue will be important, and also to make sure that the patients are in the end not lost in that, and that we maintain equal access to high quality care ultimately, I think will be absolutely essential. So thank you very much for this great discussion, for the panel. Thanks to the audience for listening and also contributing with great questions. I think it's up to me now to conclude this session. Thanks everyone. Thanks also for the great organization of the team at Gastein. Hopefully see you all in person very soon again, and we can conclude here today. Thank you very much, and goodbye.